for today, we're going to talk about immunopharmacology. Immunopharmacology is found in chapter 55 in Kadzung book. So first, we are going to read or know the lesson objectives. There are 5 lesson objectives. First is we have the describe the immune response and how different immune cells work together to protect the body. Second is identify the mechanism of action and uses of the cytotoxic, non-cytotoxic, and monoclonal antibodies indicated for immunosuppression. Third, identify the mechanism of action and uses of the interferons, interleukins, and colony-stimulating factors involved in immunomodulation. Fourth is discuss the 7 immunosuppressants and for each describe the mechanism of action and clinical uses and toxicities. And lastly is we have to describe the different types of allergic reactions to drugs. First is what is immunopharmacology? Immunopharmacology deals with drugs acting on the immune system and in addition with the pharmacologic actions of substances derived from the immune system. In order to lend sharper definition to the term immunopharmacology, the subject matter has been divided according to clinical and pragmatic criteria. The division into immunosubstitution, immunosuppression, anti-allergic substances, and immunostimulation gives the heterogeneous material a tighter structure than would any classification according to origin, chemical structure, or mechanism of action. So, although the immune system is essential for protection against pathogens, in certain instances, its powerful destructive mechanisms do more harm than good. Examples include hypersensitivity reactions, autoimmune disorders, and rejection reactions to transplanted tissues. Drugs that suppress the immune mechanism play an important role in treating these conditions. Increasingly, monoclonal antibodies targeting proteins with K rules and immune responses are being developed as immunosuppressive agents. In some situations, drugs that potentiate the immune response provide benefit. So here is in the picture you will see the graph of drugs that modulate immune function. We have the immunosuppressants and immune potentiators. In immune potentiators, it is divided by aldehydes, leukin, and interferons. In immunosuppressants, we have the corticosteroids, prednisone, immunophilin ligands, and cyclosporine, tacrolimus, or Silimus. And third is mycophenolate, mofetil. Fourth is cytotoxic drugs. We have the azathioprine. Last is immunoglobulin-based agents. Next is identify the mechanism of action and uses of the interference and colony-stimulating factors involved in immunomodulation. So, monoclonal antibodies intended to bind the specific targets often expressed on the immune system and to treat various immunopathological. Second is it is considered to have a high potential for immunotoxicity, which is reflected in the clinical experience accumulated on mAbs-induced adverse effects related to immunosuppression, immunostimulation, and hypersensitivity or immunogenicity. Next is what is cytokines? It is a cell signaling group of low molecular weight extracellular polypeptides or glycoproteins synthesized by different immune cells, mainly by T cells, neutrophils, and macrophages, which are responsible to promote and regulate immune response. Examples of these are activity, differentiation, proliferation, and production of cells and other cytokines. These polypeptides act on signaling molecules in cells, stimulating them toward sites of inflammation, infections, traumas, acting on primary lymphocyte growth factors, and other biological functions. Next is cytokines act in the site where they are produced, or autocrine action in nearby cells, or paracrine action, or in distant cells, endocrine action. In this sense, they are important in the development and regulation of immune system cells. Next is we have the mechanism of action and its uses of your interferons. Interference derives from the ability of these cytokines to interfere with viral replication. Type 1 interferons present a potent antiviral effect by inhibiting viral replication, increasing the lysis potential of natural killer cells, and the expression of MHC class 1 molecules in virus-infected cells and stimulating the development of Th1 cells. So, interferons inhibit varying stages of viral replication, including viral entry, encoding, mRNA synthesis, and protein synthesis. Interferons have profound immunomodulatory properties. The immune response to interferons alpha appears to be critical to clearance of hepatitis B and C. Interferon family represents a widely expressed group of cytokines, and it includes three main classes designated as type 1 interferons, type 2 interferons, and type 3 interferons. This medication is used to treat various cancers. Examples: leukemia, melanoma, AIDS-related Kaposi sarcoma, and it is also used to treat virus infections. Examples of your virus infections are chronic hepatitis B, chronic hepatitis C, condylomata, and acominata. These medications is the same as a protein that your body naturally produces, or your interferon. In the book, in chapter 55, Kadzong, in table 55-2, titled The Cytokines, you will see the different interferons up to, including interleukin, up to interleukin 35 that we will discuss later on. So next is we have the interleukins. Interleukins is a type of cytokine first thought to be expressed by leukocytes alone but have later been found to be produced by many other body cells. It plays essential roles in the activation and differentiation of immune cells as well as proliferation, maturation, migration, and adhesion. They also have pro-inflammatory and anti-inflammatory properties. So, what is the primary function of your interleukins? So, the primary function of your interleukins is to modulate growth, differentiation, and activation during inflammatory and immune responses. It consists of a large group of proteins that can elicit many reactions in cells and tissues by binding to high affinity receptors in cell surfaces. And it also have both paracrine and autocrine function, used in animal studies to investigate aspects related to clinical medicine. So next is we have here the different interleukin. Before I forgot, let's go back to interferons. Interferons are proteins that are currently grouped into three families: interferons A, interferons B, and interferons Y. The interferons A and interferons B families constitute type 1 interferons, which the examples of these are acid stable proteins that bind to the same receptor on target cells, while your interferon Y is a type 2 interferon that is acid labile and binds to a separate receptor on target cells. Next is, we go back to your interleukins. Interleukin. So we have here the first interleukin 1, or IL-2, is a macrophage's large granular lymphocytes, B cells, endothelium fibroblasts, and astrocytes secrete 1L-1. T cells, B cells, macrophages, endothelium, and tissue cells are the principal targets. And it also causes lymphocytes activation, macrophage stimulation, increase in the gut. And next is interleukin 2, or IL-2. T cells produce IL-2. The principal targets are T cells. Its primary effects are T cell proliferation, differentiation, increased cytokine synthesis. Interleukin 3, or T cells and stem cells, make interleukin 3. Functions as a multi-lineage colony stimulating factor. Then your interleukin 4 is TH2 and CTL activation, B cell proliferation, or CD4, plus T cells synthesize interleukin 4 and acts on both B and T cells. It is a B cell growth factor and causes hemoglobin E and hemoglobin G1 isotype selection. It causes Th2 differentiation and proliferation, and it inhibits interferons, gamma mediated activation, and macrophages, and it promotes mast cells proliferation in vivo. So interleukin 5 or IL-5 is the eosinophil proliferation, B cell proliferation, and differentiation are the properties. So in next is your interleukin 6 or IL-6. The properties of your IL-6 is HCF, Th2, CTL, and B cell proliferation. In interleukin 7, CTL, NK, LIK, and BC, B cell proliferation, thymic precursor and stimulation, or the bone marrow stromal cells produce interleukin 7 that acts on pre-B cells and T cells. It causes B cell and T cell proliferation. In your interleukin 8 or IL-8 is the properties of this are neutrophil, chemotaxis, pro-inflammatory, and it is the monocytes and fibroblasts makes IL-8. Its principal targets is what I've said earlier: neutrophils, basophils, mast cells, macrophages, and keratinocytes. In interleukin 9 or IL-9, the properties of this are just T cell properties, T cell proliferation. In interleukin 10 or IL-10 is Th2 cell produce IL-10, and principal targets are Th1 cells. Next is, you can read the other interleukin 11 to 35 in the book in table 55-2. Next is, what is the colony stimulating factors? Colony stimulating factors are substances that stimulate the production of blood cells and promote their ability to function. They do not directly affect tumors, but though they rule in stimulating blood cells, they can be helpful and as support of a person's immune system during cancer treatment. Closely associated with interleukins 3 and interleukin 5, which is in your interleukin 3, hematopoietic precursor proliferation and differentiation, and in your interleukin 5, the eosinophil proliferation, B cell proliferation, and differentiation. While there is no significant amino acid sequence homology between the three, they exhibit a number of biological similarities. Colony stimulating factors has been shown to be the integral signal factor along with interleukin F1 in interleukin 1 and activin produced in the pre-implementation development in a number of mammals, including humans, mice, pigs, and cows. Treatment with colony stimulating factors in cows during in vitro fertilization was able to significantly reduce pregnancy loss and enhance embryonic competence for post-transfer survival. The lack of colony stimulating factors in knockout mice have shown smaller birth size, fatal growth retardation, and increased mortality within the first 3 weeks. So next part is we are going to discuss about the different types of allergic reactions to drugs. So first we have your type 1 allergic reaction. Hemoglobin E mediated acute allergic reactions to stings, pollens, and drugs, including anaphylaxis, urticaria, and angioedema. Your immunoglobulin E belongs to heavy chain epsilon, and the structure is monomer. The function or rules of your immunoglobulin E is important in protection against parasites. Second is they are involved mainly in the development of allergic responses. Third, the release of histamine. Fourth is which produces contraction of smooth muscles. And lastly, it stimulates secretion of mucus. Immunoglobulin E is fixed to tissue mast cells and blood basophils, and after interaction with antigen, the cells release potent mediators. Next is we have your type 2 allergic reaction. Type 2 drugs often modify host proteins, hereby eliciting antibody responses to the modified protein. This allergic response involves immunoglobulin G or immunoglobulin in which the antibody becomes fixed to a host cell, which is then subject to complement or dependent lysis or antibody dependent cellular cytotoxicity. Your cytotoxicity. So in so examples of your autoimmune type 2 reactions to drugs is certain autoimmune syndromes can be induced by drugs. Examples are these are systemic lupus erythematosus following hydralazine or procainamide therapy, or lupus hepatitis due to cathartic sensitivity, autoimmune hemolytic anemia resulting from methyl-dopa administration, thrombocytopenic purpura due to quinidine, and agranulocytosis due to a variety of drugs. In type 2, the allergic response involves immunoglobulin G or immunoglobulin M. In immunoglobulin G, it is a gamma Y heavy chain, and the structure is also a monomer only, like immunoglobulin E, and has functions or rules of the ability to traverse the blood vessels to tissues, pass through the placenta to the fetus, and third is important in the secondary response, while your immunoglobulin M or U is a pentamer structure and functions produced in the primary immune response. Second is they are restricted to the bloodstream due to high mass. Third is important in the primary response. Next is we have the type 3. Type 3 belongs to drugs that cause serum sickness, which involves immune complexes containing immunoglobulin G, also, which is complex with a foreign antigen and is a multi-system complement dependent vasculitis that may also result in urticaria. In type 3, it is more common than immediate anaphylactic responses, but your type 2 and your type 3 hypersensitives often overlap. The clinical features of serum sickness includes urticarial and erythematous skin eruptions, arthralgia or arthritis, lymphadenopathy, glomerulonephritis, peripheral edema, and fever. The reactions generally last 6 to 12 days and usually subside once the offending drug is eliminated. Antibodies of the immunoglobulin M or immunoglobulin G class are usually involved. Glucocorticoids are useful in attenuating severe serum sickness reactions to drugs. In severe cases, plasmapheresis can be used to remove the offending drug and immune complexes from circulation. And lastly is we have your type 4. Your type 4 allergic reactions to drug are cell-mediated. Allergy is the mechanism involved in allergic contact dermatitis from topically applied drugs or induration of the skin at the site of an antigen injected intradermally. So in your type 4 hypersensitivity, it occurs during 24 to 48 hours after exposure to the allergen, and therefore it is called delayed type hypersensitivity. So your type 4 is also called delayed type hypersensitivity or DTH. Like other drugs hypersensitivities, the drug may chemically react with host tissue to create a new antigen. Upon first exposure to the allergen or drug, antigen presenting cells stimulate T cell response specific for the allergen. It also takes 1 to 2 weeks upon second and all subsequent exposures. Tissue derived antigen presenting cells that come in contact with the new antigen or allergen modified host protein that secrete chemokines and cytokines that attract memory T cells to the site of allergen re-exposure.
The next one is describe the immune response and how the different immune cells work together to protect the body. So immune response is describe how your body recognizes and defends itself against bacteria, viruses, and substances that appear foreign and harmful. So the next one is the type of immune system is the first one is innate immune system. So innate immune system is defined as the first line of defense against invading pathogens such as bacteria, viruses, fungi, parasites, and consists of mechanical, biochemical, and cellular components. So the cellular components of the innate immune system is neutrophils, monocytes, macrophages, natural killer cells, and natural killer T cells. So complement components enhance macrophage and neutrophil phagocytosis by acting as opsonin and chemoattractant, which recruit immune cells from the bloodstream to the site of infection. So the activation of the complement eventually leads to pathogen lysis via the generation of a membrane attacks complex that creates holes in the pathogen and killing it. So during the inflammatory response triggered by the infection, neutrophils and monocytes enter the tissue sites from the peripheral infections. This cellular influx is mediated by the action chemoattractant cytokines or also called chemokines. So the macrophage chemotoxic protein 1 and macrophage inflammatory protein 1A are released from the activated endothelial cells and immune cells, mostly tissue, macrophage, and inflammatory sites. In addition, monocytes and neutrophils, natural killer cells, natural killer T cells, and gamma delta T recruited to the inflammatory site contribute to the innate response by secreting interferon gamma and interleukin-17, which activate resident tissue and macrophage and dendritic cells and recruit neutrophils respectively to successfully eliminate invading cells. So, NK cells or natural killer cells are so called because they are able to recognize and destroy virus-infected normal cells as well as tumor cells without prior stimulation. This activity is regulated by killer cell immunoglobulin-like receptors on the NK cells surface that are specific for major histocompatibility complex class 1 molecules. NK cells bind self-MHC class 1 proteins expressed in nucleated cells. This receptor deliver inhibitory signals preventing them from killing the host cells. So, next one is the adaptive immune systems. So, the antigen presenting cells include before that, let us define the adaptive immune system. It is defined as the induction of a specific adaptive immune response participation of professional antigen presenting cells. So this includes dendritic cells, macrophages, and B lymphocytes. So their capacity to phagocytize particular antigen or endocytose proteins antigen and enzymatically digest them to generate peptides, which are then loaded onto class 1 or class 2 MHC proteins and presented to the cell surface T cell receptor. So the next one is identify the mechanism of action and uses of the cytotoxic, non-cytotoxic, and monoclonal antibodies indicated for immunosuppression. So first one is cytotoxic. Cytotoxic is defined as work as prevent self-division or cause cell death. So, the first example of cytotoxic drugs are azathioprine. So, azathioprine is a product of mercaptopurine, and like mercaptopurine, it functions as metabolite. Although its action presumably mediated by conversion to mercaptopurine and further metabolites, it has been widely used as mercaptopurine for immunosuppressant in humans. These agents represent prototypes of antimetabolite group of cytotoxic immunosuppressive drugs. So, the mechanism of action of azathioprines appear to produce immunosuppression by interfering with purine nucleic acid metabolism at steps that are required for the wave of lymphoid cell proliferation that follows antigenic stimulation. So the purine analogs are the cytotoxic agents that are discharged stimulated lymphoid cells. Although continued messenger RNA synthesis is necessary for sustained antibody synthesis is necessary for sustained antibody synthesis by plasma cells. So these analogs appear to have less effect on this process than on nucleic acid synthesis in proliferating cells. So cellular immunity as well as primary and secondary serum antibody responses can be blocked by these agents. So the clinical uses of the azathioprine appear to be of definite benefit in maintaining renal allografts and may be of value in transplantation of other tissues. So next one is non-cytotoxic agent. Non-cytotoxic agents are defined as a pharmacologic substance that does not directly kill cells but instead affects cellular transport and metabolic function to ultimately produce cell death. So the one of the drugs that belongs to non-cytotoxic agents is acitretin. So acitretin has a mechanism of action. The mechanism of action of the acitretin is unknown. However, acitretin causes modulation of cellular differentiation in the epidermis apoptosis and in a fragmentation in sensitive T cell lines. So acitretin also causes modulation of the immune response. So the clinical uses of acitretin is lymphoma or cutaneous T cell. So the next one is monoclonal antibodies. So there are different types of monoclonal antibodies according to uses, but I only give at least one drugs belong to each types of monoclonal antibodies. So next, the first one is anti-tumor monoclonal antibodies. The drug that belongs to anti-tumor mobs is alemtuzumab. Its mechanism of action is humanized IgG1 with a Kappa chain that binds to CD52, found on normal and malignant B and T lymphocytes, NK cells, monocytes, macrophages, and small population of granulocytes. But for and the description of the additional description of alemtuzumab is wait. So next one is clinical uses. So for the clinical uses of the alemtuzumab was previously approved for the treatment of B-cell chronic lymphocytic leukemia in patients who have been treated with alkylating agents and have failed fludarabine therapy. So alemtuzumab also appears to deplete leukemic cells by direct antibody-dependent lysis. More recently, alemtuzumab was approved by the EU for the treatment of patients diagnosed with relapsing remitting multiple sclerosis in the latter. In the latter, alemtuzumab depletes to autoimmune inflammatory T and B cells while the drug is in the circulation. The next type of monoclonal antibodies is immune checkpoint inhibitor MAPs. So the drug that belongs to this type is ipilimumab. So the mechanism of action of ipilimumab is bind to CTLA-4 on T cells, preventing CD80/86 from delivering a suppressive signal to T cells. This has the effect of maintaining T cell activation. So, the clinical uses of the ipilimumab is it is approved for the treatment of unresectable or metastatic melanoma and treatment of cutaneous melanoma with regional nodes in the adjuvant surgical setting. So, the next type of monoclonal antibodies is MABs used to deliver isotopes and toxins to tumors. So the drug that belongs to this type is ebritumumab thiocictan. So it is an anti-CD20 murine monoclonal antibody with isotopic yttrium or 11IN. So the mechanism of action of this drug is the radiation of the isotope coupled to the antibody provides the major antitumor activity of this drug. So clinical uses of this drug is it is approved for the use of the patient with relapsed or refractory low-grade follicular or B-cell non-Hodgkin's lymphoma, including patients with rituximab refractory follicular disease. It is used in conjunction with rituximab in a two-step therapeutic regimen. So, the next type of monoclonal antibodies is MABs and fusion proteins used as immunomodulatory and anti-inflammatory agents. So the example of this type is abatacept and belatacept are recombinant fusion proteins. So the mechanism of action of these drugs composed of the extracellular domain of cytotoxic T lymphocyte associated antigen 4 fuse to the Fc domain of human IgG1. So the clinical uses of this drug is the abatacept is approved for use in rheumatic and other forms of arthritis, while belatacept is approved to help prevent rejection in kidney transplant. The fusion of these both proteins block the activation of T cells by binding CD80, blocking the CD28 activation signal in T cells. So the next one is discuss the 7 immunosuppressants and 4 each describe the mechanism of action, clinical uses, and toxicities. So the first immunosuppressants is antibodies. The drugs that belongs to these immunosuppressants will be discussed. So first one is alemtuzumab. Its mechanism of action is a humanized alemtuzumab is a humanized monoclonal antibody, has a mechanism of action that binds to CD52 on both T and B cells, resulting in depletion of both lymphoid cell lines. Depletion of the T and B cells is observed soon after infusion, and recovery of these cells is gradual. T cells recover over 6 to 12 months and B cells recover in 6 months or less. So the clinical uses of alemtuzumab is it is approved for the treatment of chronic lymphocytic leukemia, but has been used in transplantation as an induction and anti-rejection agent for both acute cellular rejection and antibody-mediated rejection, due to its activity against both T and B cells. Because of the potent and prolonged immunosuppressive effect, it is recommended to initiate or display prophylaxis for pneumocystis, pneumonia, and herpes viruses after administration of alemtuzumab. So the toxicities of alemtuzumab is infusion-related effects, chills and fevers, severe and prolonged leukopenia, neutropenia, thrombocytopenia, infections such as CMV, HSV, and other viruses and fungi. So the next one belong to antibodies is anti-thymocyte globulins. Its mechanism of action is they cause depletion of circulating T cells and apoptosis of activated T cells. So the clinical uses of this drug is it is a primary use at the time of transplantation to prevent early allograft rejection, along with other immunosuppressive agents. It may also be used to treat severe rejection episodes or corticosteroid-resistant acute rejection. It is usually used for 3 to 10 days to produce profound lymphopenia, and that may last beyond 1 year. So the toxicities of this drug is prolonged use may be associated with profound immunosuppression and an increased risk of opportunistic infection and or post-transplant lymphoproliferative disease or PTLD. Next immunosuppressant is calcineurin inhibitors. So the mechanism of action of cyclosporin and tacrolimus, these are the drugs that belong to calcineurin inhibitors. Its mechanism of action is block signal transduction through the calcineurin pathway, activated downstream of signal 1. To impair T cell activation, calcineurin, a calcium-dependent protein phosphatase, dephosphorylate the dysphosphorylates nuclear factor of activated T cells, allowing infant to enter the T cell's nucleus and binds to DNA, leading to transcription and production of cytokines, including IL-2. So cyclosporin binds to cyclophilin, whereas tacrolimus binds a protein called binding protein or FKBP. So the clinical use of this drug is tacrolimus is the preferred calcineurin inhibitor due to its decreased rate of allograft rejection as compared to cyclosporine. Although it is approved for renal, liver, and heart transplant, tacrolimus is the mainstay of maintenance immunosuppressant for all solid organ transplant. Infections are possible with use of calcineurin inhibitors, and recipients are often given prophylactic medication post-transplant. So, calcineurin, the calcineurin inhibitors toxicities is the nephrotoxicity, which has led to the development of regimens using these agents in combination with other immunosuppressive drugs. So, hirsutism or excessive hair growth is the common adverse effect of cyclosporine. The next one is costimulation blocker. So the drug that belongs to this immunosuppressant is belatacept. A second generation costimulation blocker is a recombinant fusion protein of CTLA4 which like CD28 binds to CD80 and CD86 on APC. Binding of belatacept to CD80 and CD86 prevents CD28 from binding to those molecules and thus inhibits signal 2 of the T cell activation pathway. So that is the mechanism of action of belatacept. Clinical use of this drug is approved for kidney transplantation in combination with bacilicimab, mycophenolate mofetil, and corticosteroids. This drug can substitute for calcineurin inhibitors to avoid the detrimental long-term nephrotoxic, cardiovascular, and metabolic complications seen with cyclosporine and tacrolimus. So notice for this one is the first generation costimulation blocker abatacept is approved for rheumatoid arthritis. So the toxicity of this drug is belatacept increases the risk of PTLD, particularly of the central nervous system. Therefore, it is contraindicated in patients who are seronegative to Epstein-Barr virus, a common cause of PTLD. So next one is mTOR inhibitors. So mTOR inhibitors, it has a drug that belongs to this inhibitors is sirolimus and everolimus. It has a mechanism of action that inhibit the protein mTOR, blocking the signal transduction pathway activated by signal 3. Progression into the cell cycle and T cell proliferation is subsequently prevented. So the clinical uses of this is mTOR inhibitors are commonly used in multi-drug regimens frequently to minimize the dose of calcineurin inhibitors and spare for nephrotoxic adverse effect. So The anti-proliferative action of sirolimus is also valuable in cardiology, where sirolimus-coated stents are used to inhibit restenosis of the blood vessels by reducing proliferation of endothelial cells. So, everolimus is also used in oncology to treat many different types of cancer, including breast, renal cell, and neuroendocrine tumors. However, the doses for tumor treatment are higher than those used in transplantation. So the toxicity of this drug is HTN, HLD, stomatitis, proteinuria, impaired wound healing, rash, myelosuppression, pneumonitis, and also pneumonitis. So the next one, immunosuppressant, is antiproliferatives. So the anti-proliferatives azathioprine and mycophenolate block lymphocyte proliferation by inhibiting nucleic acid synthesis. So azathioprine, which was one of the first agents to achieve widespread use in organ transplantation, is a prodrug that is converted first to 6-mercaptopurine and then to the corresponding nucleotide analog, thioinosinic acid. So the analog is incorporated into nucleic acid chains and blocks further elongation of the DNA. So mycophenolate is a potent reversible non-competitive inhibitors of inosine monophosphate dehydrogenase, which blocks the de novo formation of guanosine monophosphate. Because of lymphocytes are unable to utilize the salvage pathway of the nucleotide synthesis, mycophenolate effectively blocks T and B cell proliferation by eliminating de novo production of guanosine monophosphate. So, the clinical use of these drugs is these drugs are used as adjunctive immunosuppressant agents, primarily with calcineurin inhibitors with or without corticosteroids. So, mycophenolate has largely replaced azathioprine in this role due to its improved safety and efficacy profile. So, mycophenolate is available in two formulations. As a prodrug, mycophenolate Mofetil, and as an active drug, mycophenolate acid. So mycophenolate Mofetil is rapidly hydrolyzed in the gastrointestinal tract to mycophenolate acid. So mycophenolate acid is an enteric-coated tablet designated to theoretically reduce the gastrointestinal upset commonly experienced with mycophenolate Mofetil. So the toxicities of this drug is the main dose-limiting adverse effect of azathioprine is bone marrow suppression. Allopurinol inhibit the metabolism of azathioprine, thereby enhancing the adverse effect of azathioprine. Thus, concomitant use of allopurinol requires a significant reduction in azathioprine dose. So, the next one is corticosteroids. The mechanism of action is the exact mechanism responsible for the immunosuppressive action of corticosteroid is unclear. The T lymphocytes are most affected. The The steroids are able to rapidly reduce lymphocyte population by lysis or redistribution. On entering cells, they bind to the glucocorticoid receptor. The complex passes into the nucleus and regulates the transcription of DNA. So the clinical use of corticosteroids is the corticosteroids were the first pharmacologic agent to be used as immunosuppressive, but both in in transplantation and in virus autoimmune disorder. They are still one of the mainstay for attenuating rejection episodes. For transplantation, the most common agents are prednisone and methylprednisolone, whereas prednisone and prednisolone are used for autoimmune condition. So, note is in transplantation, they are used in combination with agents described agents. So the toxicities of this drug is HDN, HLD, hyperglycemia, peripheral edema, mood disturbances, osteoporosis, weight gain. So the other immunosuppressant is that belongs to this is the other drug that also belongs to immunosuppressants is intravenous immunoglobulin. Its mechanism of action is not well defined, but high doses of IVIG appear to induce B cell apoptosis and modulate B cell signaling. It also high doses of IVIG appear to induce B cell apoptosis and modulate B cell signaling. So, the clinical uses of IVIG contains immunoglobulins prepared by human plasma pulled from many donors. It has immunomodulatory effect and is often used to autoimmune diseases. Pre-transplant desensitization protocols and treatment of AMR. The immunomodulator effect on T and B cells occur at high doses, and it is also used at lower doses to prevent infection by replacing immunoglobulins removed during plasmapheresis. So the toxicities of this drug is headache, fever, chills, myalgias, and hypotension or hypertension, which can be reduced by slowing the infusion rate. So, for the serious adverse effect is aseptic, meningitis, acute renal failure, and thrombotic events. So the other drug that also belongs to immunosuppressants is bortezomib. Its mechanism of action is a proteasome inhibitor that leads to cell cycle arrest and apoptosis of normal plasma cells, thereby decreasing antibody production in synthesized patients. Its clinical uses is approved for the treatment of multiple myeloma, but it has been adopted for use in the treatment of AMR in transplant patients. So the toxicities of this drug is hepatic dysfunction has been really reported when multiple cycles are given. So that's all our report. Thank you for listening, everyone, and have a nice day. God bless.